Thanks, Lavinia, for an excellent presentation. We are a little over time, but I think you'll all agree that we've had some excellent presentations tonight, and that's reflected in some of the questions that are starting to come through. Now, unfortunately, we won't have time to cover all our questions, but I think that we can see that many of our viewers tonight are particularly interested in some of the nuances of the pathology reports, and so hopefully we can cover a lot of these questions. I might just get the ball rolling and direct some questions at our pathologists, and perhaps start with you, Stephen, and ask Caroline and Jen to sort of also comment. It's clear that we have an overwhelming amount of information in all these molecular pathology reports, and there's many sort of downstream functions like selecting the right therapy and what to do on progression. I wonder, when you're looking at the sort of, nuts and bolts of these pathology reports, are you seeing a sort of convergence of ways that we are summarising these, or are we sort of diverging? And how do you sort of make sense of this for those of us who are perhaps not lucky enough to work in a centre where we've got a precision medicine clinic or a molecular MDT? Where are you seeing that going as pathologists in the near future?
I think in the early days, pathology really developed almost in-house tools to try and report what is known as tertiary analysis level and actually get a report out. There are some really quite good commercial vendors that sell platforms now that also give reports in a much, I would say, better formatted manner, that are clearly laid out with an executive summary and then clearly demarcated variants, tiers, what the tiers mean, and then a comment section about whether the therapy is sensitive or resistant, and then maybe even clinical trials as well. So I think we are improving, but there is still a lot of variation between laboratories and between tests as well. Many labs, as part of their accreditation, have to adopt quality assurance programs, and many of those feed back to laboratories what they should be mentioning at a very minimum. And so I suppose from that perspective as well, I think there'll be further improvements. So I think there is a little bit more convergence about what should go on a report. I think Caroline and Jen outlined what definitely should go on, but I think the formatting and the way it's actually presented can be quite important. You don't want a 17-page report. You want something that's easy to actually absorb and get to the point. And I think we're trying very hard, certainly, to get that down to a one-pager where most of the information is.
We've got a question from the floor that sort of follows on from your comment, asking, in the context of these molecular pathology reports, do you think we should have approved drugs relevant to those variants to be listed alongside their classifications, particularly given that many of these platforms are aggregating that information? I wonder if Jen or Caroline, you have any sort of further comments on what you're sort of seeing when you do get on the phone to clinicians. Is that something that people are asking frequently for?
Yeah, I mean, I think it's something that should definitely be included. I think there's a tendency to include drug classes rather than specific drug names, just because of the rapid change in the field and wanting to give the kind of decision-making back to the oncologist. But it depends on the lab. As Stephen said, there is variability between the labs. I think it's why it's partly so important to have the guidelines, such as these non-small cell lung cancer guidelines that kind of do explicitly say what should be tested, when it should be tested, how it should be reported, etc. I think that's something that needs to be done for other tumor types as well. And it's definitely, there could be more cohesion within Australia. We recently formed the Australasian Molecular Pathology Society and having the first meeting for that. So I think one of the aims of that is going to be to have more standardization of the reports. But yes, they should all include at least a drug class when there is a targeted therapy available for a variant.
Excellent. We do have another question, speaking of variants, and this is actually a question which I've frequently pondered myself. and that is, how do we distinguish clonal from subclonal variants? I guess we see some of these subclonal variants particularly coming out at progression, as we've seen tonight. Is that as simple as basing that on the variant allele frequency in relation to the tumour purity, or are there other things that you might look for as pathologists if you're giving us oncologist advice about that? Might that throw that one open to all three of you from the pathology side?
It's a blunt tool. We can infer from the VAFs that there may be subclones of a particular variant, but you don't truly know. Often our estimates, if it's not a computational method, our estimates of tumour cellularity as pathologist is not always, shall I say, terribly accurate, even between the same pathologist on different days. So you have to take it with a little bit of a pinch of salt.
But my two cases, I mean, do you hear me when I say it's unusual for fusions? You know, you think if you see a fusion, you know, we're more confident. Or is that just my starry eyes?
Again, it's all assay dependent. The number of reads you need to get over the line to call a confident fusion depends on the assay and a number of other QC variables. So I wouldn't like to comment on your particular case now.
Sorry.
Excellent. Now, we've had a couple of questions about liquid biopsies, and I know that this is an area where the coverage is still very patchy, and we hope that Aspiration 2 will actually give us with additional real-world evidence to justify that being made available on a more widespread basis. I guess I'll direct this at you, Lavinia, since you did bring that up. Can you sort of give us an idea of, you know, outside of the trial setting, what's this look like for patients? And, you know, is that something that's available in a widespread fashion? And I guess a corollary of that is, how do you approach that discussion with your patients, especially when we don't know what to do with all that information sometimes?
Yeah, so I think there's definitely private labs who can offer liquid biopsies. Obviously, you know, we have to tell patients that, you know, they have to pay for it. I mean, I'm lucky enough to be working at Peter Mac, so, you know, we do have, you know, some liquid biopsy tests that we can do for our lung cancer patients, thanks to Stephen's lab and pathology. So that's a good thing. But yeah, I mean, the common ones, you know, Foundation 1, Garden 360. So that's available and very easy to use. Yeah, quite straightforward. Patients can go to a path lab that's affiliated to them, and they can pay for it. I think if you tell patients, you know, what are the pros and cons, how much it costs, and most patients will, decide for themselves.
Stephen mentioned in his talk earlier something about sort of thinking about context dependence of some of these mutations. You know, thinking about how we apply these, do you think that liquid biopsy is something that will mean we need to sort of have non-small cell lung cancer only trials, or will there be benefit in sort of looking across these mutations in different baskets? What are you sort of seeing on the liquid biopsy side and implications for clinical trial design? Mel, any comments?
Sorry, I was waiting to see who that was.
Sorry, who was the question for?
Well, I guess we've seen that molecular variants can have different meanings in different, you know, tumour subsites. We heard about how KRAS at the moment may be one of those examples. However, I do think we're forging into a space where there should be molecularly sort of focused trials and therapeutics, particularly when the drug's really active. I think that, you know, we would feel more comfortable using that molecular profile, you know, in that basket approach that you've alluded to. So, yeah, that's a generic answer, but I think definitely it's the current, but definitely also more the future.
We do have one last question, or in fact, I think you've answered it there, Stephen, a question about your case, Mal.
Sorry.
Yeah.
Because I presented 400 cases, it might be hard to know which one. But the one that we were talking about, the liquid biopsy case, actually, yes, that was a squamous cancer on the cytology, but I guess a never smoker, it's often an adenosquame, and it just didn't quite make sense clinically to me. And her other sites of disease weren't biopsiable, and there wasn't the opportunity to do another bronch biopsy. So that's where the liquid came in, and yes, she paid for it, and it was certainly very worthwhile, as I've avoided sort of futile immunotherapy, which strictly speaking, a squame, non-PD-L1 expressing, that's really the pathway we're going down. So that was that case, I think, asked about.
But just a note of caution that not all liquid biopsies are equal. And just like in tissue testers, there are a lot of different technologies and methodologies, and they all have different limits of detection. So do a little bit of homework if you're going to select a test.
Yeah, excellent. Just to sort of wrap things up tonight, I guess we're getting a little bit close to 8:15, and everyone probably wants to get off. I guess to round out the discussion, Mal, a lot of your cases, we've got a lot of different drugs being thrown in there, and it's not as simple as having one EGFR inhibitor and one ALK inhibitor. Curious to know how you sort of approach these discussions with your patients. Do you wait till you've got, what sort of level of evidence do you wait to when you're discussing these therapies? I know there's a lot of, that's probably opening up a can of worms, but
no, I mean, you know, it takes a lot of time. I mean, I work in a sort of demographic of highly educated people, so they've already worked out which liquid assay they'd like to do. So guess that makes our job a little bit easier. But you're right. The reason it's going to be hard for us to get sort of Medicare approval of liquid in the drug resistant space is it is not meaning like it did for T790M. You go on to osimertinib, that's in the rearview mirror now. So really you need to be looking at sort of more rational sort of potential combinations of therapies with lower levels of evidence. But as we heard from Lavinia, I mean, drug resistance is so heterogeneous, and we've got to do the best with the sort of clinical and biological data that we have, and that person can't wait. So it's tricky because it is then largely off-label, or it's the fifth line of therapy. I mean, where are those trials? Nowhere. And we're having complex discussions on how to try and access. But we still should have them, right? We shouldn't shy away from them because we have to talk about things that are challenging or difficult. But yeah, Aspiration 2 is going to help us with some of those headaches for the 500 that come in, and I think that won't take long to recruit.
Yeah, thank you. We might wrap things up there, and I think on that note, this is a great time to sort of, again, remind everyone of TOGA's mission on the note of mentioning aspiration. I'd like to thank all of our speakers tonight for their excellent presentations, and to thank everyone who's attended tonight. We hope you've learned something new at this webinar, and we'd really value your feedback. So feel free to scan the QR code before we flash it onto the next slide to share your thoughts. Thanks once again to our sponsors. This would not be possible without the support of ISI, Merck and Johnson & Johnson. And not to forget some of the upcoming TOGA events, in particular the annual scientific meeting, which will be happening in July in Melbourne this year. And of course, there are also many opportunities to engage with TOGA throughout the course of the year. The ASCO highlights, our regular podcast, and of course, for those of you who get on social media, LinkedIn and Twitter and Sky Blue, we value your engagement. Thanks and good evening, everyone.